Welcome back to your Pediatric Dentistry channel Tiny Teeth Talk. If you are new to this channel, subscribe the channel, and for details of this channel visit the bio section, or you can also check out my first video. Sorry if there is any mistakes in videos or short. Radiographic examination is an essential part of the diagnosis of the dental disease. You might already learn about it in oral radiology, but I am covering it in a way that you get notes with the explanation and which is easy to remember and some important things to keep in mind in pediatric dentistry. The question is radiographic techniques in pediatric dentistry. Not so important question in exam for undergrads, but in master it can be asked in short note, long note, and also in essay paper 3 and many questions in viva, entrance, practical. So very important in general for both undergrads and masters. So today we discuss introduction part, which is part 1. Very fast. Let's look out first on history of radiograph. This image might help you to remember easily. The X-ray was discovered in November 8, 1895 by William Conrad Roentgen, a professor of physics at the university in Germany, by exposing his wife Bertha's hand with 15-minute exposure time. He used vacuum tube known as a crooked tube with a fluorescent plate in the darkened room. He gave the name X-ray because X for unknown rays and published paper in late December. Then in 1896, Dr. Otto Walkhoff, in January, a dentist in Germany, made the first dental use of an X-ray and radiographed a lower premolar with 25-minute exposure time. He used a small glass photographic plate wrapped in a black paper and covered with rubber. So Roentgen used fluorescent plates and crooked tube with the 15-minute exposure time, and Dr. Otto Walkhoff used a small glass photographic plate wrapped in a black paper covered with the rubber with the 25-minute exposure time. On February 1, 1896, Walter Koenig took one of the earliest dental radiographs with an exposure of 9 minutes. He used the crooked tube and photographic plate, which is the mixture of old techniques by Roentgen, who used the crooked tube, and new technique by Walkhoff, which is photographic plate. Then in 1901, William Herbert Rollins discovered the burns on the skin due to the X-ray and published the first ever radiation hazard. In 1904, Western Enterprise introduced bisecting technique. In 1913, first X-ray tube was invented by William D. Cooley, which is hot cathode X-ray tube. In 1925, bituing technique introduced by the H.R. Rapper, Howard Riley Rapper. In 1939, Morris Sokolov introduced the advancement in X-ray by optimizing anode and cathode configurations within the X-ray tube to produce the clearer and more detailed image. In 1940s, particularly 1947, F.G. Fitzgerald introduced the long con technique of radiograph, and in 1949, Finnish professor Jaakko Väli-Pataro introduced the panoramic radiograph, we call it OPG, by placing a long strip of a film in a patient mouth and rotating patient chair to capture the entire dentition in single stage, which improved the efficacy and comprehensiveness of X-ray. In 1970s, Sir Godfrey Hunsfield and Alan M. Cormack introduced the computed tomography, which is CT scan, and in early 1970s, Paul Letterber introduced the MRI, magnetic resonance imaging. In 1980s, there was an invention of the high quality generator for better X-ray image, and in 1987 there is the invention of digital radiography. In 1997, PET scan was invented. So there are some important inventions which we have to remember in dental radiographic history. Coming to the characteristic of an ideal radiography. The radiographic image should have the following characteristics to be ideal. First is the radiographic density. So radiographic density refers to overall degree of the darkening of the various regions. So it should not be very dark and it should not be very light. Latitude of the film. Latitude means the range of exposure that the film can accurately capture. Think of it like the film's ability to handle the different levels of light and dark areas in the X-ray image. So basically the dark and light areas in the X-ray are based on it. There is a two type of latitude, wide latitude and the narrow latitude. Wide latitude means the wide range of exposure. If a film has a wide latitude, it can capture a broad range of exposures. This means it can show both very light and very dark areas clearly. If the image has a narrow latitude, means the narrow range of exposure. If a film has a narrow latitude, it can only capture a limited range of exposures. This means it might not shows the detail well in the very light or very dark areas. Then adequate radiographic contrast. Contrast in a dental radiography refers to the difference in the density or the degree of blackness between the different areas of a radiographic image. It helps to distinguish between the various structures and tissues in the mouth. There is a three type of contrast: high contrast, low contrast and ideal contrast. High contrast, this type of radiograph has very dark and very light area, making the difference between structures more pronounced. It is useful for detecting caries because the decay appears much darker compared to the surrounding health tooth structures. Low contrast, this type of radiograph has more shades of grey and less distinction between the different areas. So low contraction is useful for examining soft tissue, subtle changes in the bone density. High contrast is used for the tooth decay, detecting caries. Low contrast is used for the soft tissue, and ideal contrast is the balance between the high and low contrast, providing clear and detailed image of both hard and soft tissue. It allows for accurate diagnosis of a wide range of dental conditions. Then the speed of the film. This refers to the amount of the radiation required to produce a radiographic film of a standard density. So there is a three type of speed. D speed film. This is the slowest type of film, require more radiation resulting in a higher patient exposure but better image detail. Then E speed film. This is the faster than D speed, require less radiation than D speed and reducing patient exposure with the slight compromise in the image detail. F speed, this is the fastest currently available, require the least radiation, significantly reducing the patient exposure while maintaining acceptable image quality. So proper speed film produces the proper density X-ray image, and in pediatric E and F speed film is used for the lesser exposure time. Then the sharpness, it is the effectiveness of a radiograph to precisely mark the edge. Basically it shows the clear edges, and also there are many factors affecting the sharpness of the radiograph. Then resolution, this describes the ability of radiograph to record separate structures that are close together. There are two types of resolution: high resolution and low resolution. High resolution image, the carious lesion will be clearly visible as a distinct dark spot. Here there is a filling material, so it's a clearly visible. Then the lighter enamel dentin, the edges of the lesion will be sharp, making it easy to measure its size and depth. In low resolution, the carious lesion might appear blurry or indistinct. The edges will be fuzzy, making it difficult to determine the exact size and extent of the cavity. Coming to the image quality is the overall appearance of the radiograph. There is a two type of image: high quality radiograph and low quality radiograph. High quality radiograph is a clear, well-defined edges of the tooth and surrounding structure with distinct difference between the enamel dentin and any lesion. And low quality radiograph are blurry, poorly defined edges with the difficulty in the distinguish between different tissues and identifying lesions. So in high quality radiograph all things are clearly visible, and in low quality radiograph all things are not clearly visible. Coming to the X-ray machine, so there are different parts of the X-ray machine, starting with the tube head. So tube head contain X-ray tube. This is the X-ray tube. So this is the core component where X-rays are generated. It contains the cathode and anode. Cathode is negatively charged. It produces the electrons that are accelerates towards the positive anode. These include these tungsten filaments or coiled wire made of a tungsten, which produce the electrons when heated, and the molybdenum cup, which focuses the electrons into a narrow beam and directed towards the anode. Coming to the anode, so anode is a positively charged. It consists of the wafer thin tungsten plate embedded in a solid copper rod with the purpose of converting electrons into X-ray photon. It includes the tungsten target or a plate of a tungsten which serve as a focal spot and converts bombarding electrons into the X-ray photons, and a copper stem which functions to dissipate the heat away from tungsten target. Then transformers. There is a setup transformers and step down transformer. So setup transformer increase the voltage to the high levels needed for X-ray production. For intraoral X-ray machines, the kilovoltage should be between 60 to 70 kV, and step down transformers reduce the voltage to heat the filament. It reduces the voltage around 10 volts. Then there is a lead shielding. Here there is a lead shielding. So it surrounds the X-ray tube to prevent the radiation leakage. Only X-rays going through the porthole are supposed to leave the machine. Then there is a oil. So since 99% of the collisions between the electrons and target produces heat, the machine requires to be cooled. The oil is contained in a rubber bag which is, if expand too much due to the heat absorption, is able to push a micro switch to temporarily disable the machine, so no subsequent exposure can be made. The machine will be ready for use when it has cooled down again. Then aluminum filter. So it is placed in front of the porthole. This is porthole, so it is placed in front of the porthole to filter out all the lower energy X-rays which otherwise would just be absorbed by the patient and which would not contribute to the diagnostic image. It filters out all unnecessary X-rays. The manufacturer determines the thickness of the filter based on the kilovoltage of the machine. It removes the low energy X-rays that are not useful for imaging, which could increase the patient dose. So coming to the collimator, it shapes and limits the size of X-ray beam to reduce patient exposure and improve image quality. Then the second part is the position indicating device or positioning arm. These allow the precise positioning of the tube head around the patient's head. They ensure the X-ray beam is directed accurately at the area of interest. Then there is a control panel which include the line switch for turn on the machine and turn off the machine, timer which control the duration of X-ray exposure, kilovolt peak selector, it adjusts the voltage across the X-ray tube affecting the penetrating power of the X-ray, milliampere selector adjusts the current through the filament affecting the number of X-ray produced, and exposure button activates the X-ray production. It is often a deadman switch, meaning it requires the continuous pressure to operate. Coming to the periodontic use of X-ray. So in caries, pulpal pathology, traumatic injury, problems of eruption, anomalies of development, orthodontic evaluation, history of pain, evidence of swelling, unexplained tooth mobility, unexplained bleeding, deep periodontal pocket, fistula formation, unexplained sensitivity of the teeth, evaluation of sinus condition, unusual spacing or migration of the teeth, lack of response to conventional dental treatment, unusual tooth morphology, calcification or color, evaluation of growth abnormality, altered occlusal relationship, aid in diagnosis of the systemic disease, family history of the dental anomalies, and post-operative evaluation, etc. Stay tuned for next part in which we will cover intraoral X-rays, supplementary X-rays and radiographic location procedure. If you want this PDF or any other PDF, just like, subscribe and comment your mail ID with the topic and I'll send you the PDF. New videos on Thursday evening 6 p.m. and Sunday morning 11 a.m. Also, we try to put MCQs according to topics every day or alternate day on our shorts with the answers and explanation if needed, which will help you in Viva or NEET exam. Like, share and subscribe the channel. Thank you.